Hello, and welcome to this Clinical Care Options Hematology podcast. I'm your host, Jerfis Constanzo. In today's episode, we are joined by Dr. Courtney DiNardo at MD Anderson Cancer Center in Houston, Texas, Dr. Eunice Wang from Roswell Park Comprehensive Cancer Center in Buffalo, New York, and Dr. Brady Stein from Northwestern Feinberg School of Medicine in Chicago, Illinois. Together, they will be discussing key clinical highlights and takeaways from studies in myelodysplastic syndromes that were presented at the 2024 ASCO annual meeting in Chicago, Illinois, and the EHA 2024 Congress in Madrid, Spain. This episode is part of a larger educational program entitled Congress to Clinic, Myeloid Malignancies Clinical Advances Journal Club on Emerging MPN, MDS, and AML Data. For more information on Drs. DiNardo, Wang, and Dr. Stein, along with a link to the complete program, including downloadable slide sets and clinical commentaries, please visit the show notes for this episode. Now let's hear what the experts have to say on data presented for MDS at the 2024 ASCO and EHA conferences.
Thank you for joining us. My name is Courtney DiNardo. I am from MD Anderson in Houston, Texas, and I am joined by Eunice Wang, who's the Chief of Leukemia and Benign Hematology at Roswell Park in Buffalo, New York, and Brady Stein, who's the Professor of Medicine at the Northwestern University Feinberg School of Medicine in Chicago. Thank you for joining me, both of you. I will kick us off with a discussion on emerging data in MDS. So one slide of background, just to remind everyone that, MDS is very variable. About half or more of patients with MDS are lower risk at diagnosis, with lower risk being a variable diagnosis, right, where we're saying it's low risk, but still the median survival in most cases, at least on average, is 10 years or less. And so the treatment goal in general for lower risk patients are, supportive treatments like boosters and ESAs and transfusions, and in general, watching and waiting, whereas higher risk MDS patients is where we're really trying to get in there and alter the natural disease history in general. So this is the kind of background. But I think, things definitely are changing a bit. And just the one other background slide I think is important, just as we start going through this data, is to remind folks about the MEDALIST trial. So this was the phase 3 study which led to the approval of luspatercept. This was a randomized study of luspatercept versus placebo for lower risk MDS patients with ring sideroblasts who were requiring regular red cell transfusions. And you can see here the improvement, of course, of luspatercept compared to placebo. And so in patients with lower risk MDS with ring sideroblasts, this led to the approval of lenalidomide. And so next we move to the COMMAND study. And so this was updated at both ASH and ASCO. Most recently at ASCO by Amer Zeidan, and just highlighting the fact the difference is here. So now we are looking, it's still a randomized phase 3 trial. Now we're comparing luspatercept to EPO. And this is for patients who are lower risk MDS, but who are not necessarily ring sideroblasts, right? So this is the open genomic population, but I will highlight in red along the top that about 70% of these patients did have ring sideroblasts. So even though it wasn't restricted to these patients, the vast majority of these patients did have ring sideroblasts because in general, these are lower risk patients with isolated anemia. The primary endpoint of this study was red cell transfusion independence for 12 weeks or more with concurrent mean hemoglobin increase by 1.5 grams or higher. And what you can see in this, updated COMMANDS data set is, indeed, we are seeing in blue our patients receiving luspatercept, an improvement in the duration of reduction, 50% or more reduction in red cell transfusions at 12 weeks or more, particularly in patients who are requiring 4 or more red cell units over 8 weeks. We're seeing a significant improvement in and benefit to luspatercept. So I think that's something worth highlighting. And we're also seeing a significant improvement in the time to first red cell transfusion in those patients who are randomized to luspatercept, again in blue. So really highlighting luspatercept over EPO in this kind of lower risk population. Also highlighting here the median overall hemoglobin improvement, which is about 1.5 grams per deciliter with EPO and about 2 grams per deciliter with luspatercept. And then the others, so this is a new study. This is Patel that was presented at EHA 2024. And this is looking at real-world dose escalation and outcomes in patients with lower risk MDS receiving luspatercept. So I kind of added this here because it's a real-world study in patients getting luspatercept. And I think it highlights a really important fact, which is many patients getting luspatercept need higher doses to see a response. So remember that you start luspatercept at 1 mg per kg sub-Q every 3 weeks. And if you don't respond at that dose after 6 weeks, so after 2 injections typically, then you increase. And if no response to that dose, then you can increase further to 1.33 and 1.75 mg per kg. And so most patients require these higher levels to respond. And that's what's highlighted here. And I think that's really important for people to recognize. All right. So now we'll move to kind of the newer kid on the block. So imetelstat was just FDA approved in June. So in between ASCO and EHA, there was an FDA approval June 6th. And this is specifically, again, for lower risk patients with MDS who have not responded to or who are ineligible for ESAs. Ineligibility meant that an EPO level could be a serum EPO greater than 500 would qualify you as being ESA ineligible because you're unlikely to respond. Patients were randomized in a 2-to-1 fashion to either imetelstat, 7.5 mg per kg IV every 4 weeks, or to placebo, with the primary endpoint of transfusion independence over an 8-week period. And what you'll notice is about 40% of patients respond, which is impressive, but I think what is particularly impressive is the duration of response. So responding patients really have transfusion independence, which is quite durable, and is, I think, perhaps better shown on this slide, where you're looking specifically at those patients where the hemoglobin rose at least 1.5 grams per deciliter, and you can see how much it's sustained over time looking at these various different time points. So I think that's really quite impressive. But it is important to recognize that while the hemoglobin generally improves with this agent, there is a transient but significant phase of cytopenia. So both thrombocytopenia and especially neutropenia can be seen, with far more of these lower risk patients who are randomized to the imetelstat requiring platelet transfusions and G-CSF. This seems to be generally short-lived. You'll see that it happens generally during the first two months, with the median number of platelet transfusions of 1. So, but definitely important to be monitoring and to be aware of. And their survival was not the primary endpoint, of course. We're looking at transfusion independence, but they did highlight the overall survival, and there was kind of no detriment, of course, with imetelstat on overall survival, which of course is reassuring to see. And then the last update in terms of lower risk MDS patients, this is the ASTREON study, which was presented at ASCO by Dr. Garcia-Manero. And its background for this, I should highlight that, so there was a prior AZA MDS 003 trial where 300 milligrams of oral azacitidine was given for 21 days per cycle for lower risk MDS, and it improved the rate of transfusion independence versus placebo. And there were some patients with quite durable improvements in hematology parameters in patients with low risk MDS. In this study, the ASTREON study, they're now looking at kind of a similar idea, but a decreased dosing schedule, right? So 200 or 300 milligrams for 14 days instead of 21 days. And this, again, is for patients with lower or intermediate risk MDS by IPSS-R. Overall, patients are receiving a median of about 8 cycles in both cohorts. So this is in general fairly well tolerated. In the 300 milligram cohort on the bottom left in the pie, you can see more patients in green are discontinuing due to adverse events, while in the 200 milligram cohort, more patients are discontinuing in blue due to progressive disease. But overall, the rates of adverse events are comparable. You do see, along the bottom, somewhat higher rates of treatment-related significant AEs leading to discontinuations, although in general, overall, these are fairly similar. And in terms of response, we're seeing about a 30% hematologic improvement in both of these groups. And so that just kind of highlights that may be an option for our patients with lower risk MDS who are failing the various different treatment options for our isolated anemia and those treatments. And then, as we're trying to figure out what comes next, do we have any therapies that can improve hematologic counts and transfusion requirements? And so I think this was an important update. And now we'll move to higher risk MDS, where I really wish I had a more positive update to give you. But, alas, we have yet another high risk MDS HMA combination study, which was negative. And this is the ENHANCE study, which was a large randomized double-blind study of azacitidine with either magrolimab or placebo. And I'll highlight that while this drug was not developed for patients with P53 mutations. It certainly gained a reputation as being something that was particularly effective, potentially, for patients who have these mutations. And so nearly 50% of patients that were enrolled to this study were indeed P53 mutated. You can see about half of those patients that were enrolled along the top were thought to be transplant eligible. Median age was kind of in the 70-ish year age. And unfortunately, when you look across the board in terms of overall survival and remission rates in patients with P53 mutations or not, this unfortunately was a negative study. So where does this leave us? We now have an increasing list of the various different studies that showed promise, but that have failed in combination. I did not show the sabatolimab data, but that was also updated over these summer meetings. And so I think there's still a lot of hope in the role of a hypomethylating agent with venetoclax. And there is kind of one update in terms of this. This is from the MD Anderson. Dr. Bataille presented at a propensity score evaluation of patients with high-risk MDS at our institution that had received either oral decitabine cytisiridine, versus the same oral decitabine with venetoclax. And when you look at responses on the left, you can see there is indeed a doubling of the composite remission rate, 21 to 43%, an improvement in overall response rate, fewer cycles received in the combination, which is a little bit worrisome in terms of tolerability, but you do note that almost half of the patients in the combination went to transplant, which may have something to do with it. And so I think there is still a lot of excitement and hope in this combination. And just to remind everyone that this is still an ongoing study that we are eagerly awaiting the results of what's called the Verona trial, either azacitidine with venetoclax or versus placebo for our newly diagnosed higher risk MDS. It's a co-primary endpoint of CR rate and overall survival. And I will highlight that therapy-related MDS and CMML are not allowed on this study, so may not suffer the same trouble that some of the other studies did in terms of kind of high rates of P53 mutated patients, for instance. So we shall see. And then the last abstract I want to highlight is called the IDIOM study. This is final results. And this is for either high risk or low risk MDS, but for molecularly defined IDH1 mutated MDS. So a genomic molecular subset, which is very rare in MDS, less than 5%. And patients were placed in different cohorts based on whether they had higher risk MDS that had failed azacitidine, higher risk MDS that was treatment naive, or lower risk MDS that had failed EPO. And patients received ivosidenib. And if they responded, they stayed on ivosidenib. If not, you could add azacitidine. And what is really quite notable is the impressive responses. Overall response rate, more than 2/3 of patients. Median survival, duration of remissions are not reached. And so this does kind of highlight the fact, and actually I'll highlight along the top, you can see 33% of these patients that were considered high-risk MDS were actually low blast AML, somewhere like 20 to 30% of blasts. And so it really kind of, again, highlights the effectiveness of this targeted strategy in that rare but very relevant subset of patients who have MDS or kind of an evolving AML with low blasts and an IDH1 mutation.
So I just had a practical questions. In our center, we are using the IPSS-M, which is using the mutational information. And we are using this online calculator. And in addition to calculating IPSS-R, IPSS, we're using IPSS. And we've actually found in some patients, it actually can make a big difference that there is patients that would be rather like low or intermediate, maybe by IPSS and IPSS-R respectively. But then because they have specific mutations which aren't detected otherwise, they end up being higher risk. And so we've been leaning more on the IPSS to predict, particularly for younger patients, whether they should get transplant consults or maybe starting HMA a little bit earlier. So I was wondering what the uptake of the IPSS is in your centers, because I noticed from the poll that not a lot of people in the community are using NGS panels. And so therefore they're by definition not using IPSS-M. So I guess I was curious. We have found it to be very useful to sort of upscale some of our patients, but I don't know what your experience has been, Courtney.
I think it is it is increasingly important to know the molecular mutation status of your MDS patients. We don't have as many targeted treatments for MDS as we do in AML, for instance, but knowing, are they SF3B1 mutated in conjunction with ring sideroblasts is very relevant. If they have a P53 mutation, knowing if they have an IDH1, we just talked about the idiome data. So I think it's relevant for treatment, but it's very relevant for kind of just standard prognostication. I found the IPSS-M to be really nice, and especially in some of my patients who are particularly the type of patient that wants a lot of data and wants a lot of numbers, showing them that information, assuming that they want to see, but, pulling that up and doing the IPSS in clinic, I think is really helpful to help people get a sense of what their disease is and what to anticipate. And transplant considerations is a great point. I'm a little bit surprised that the number of people on this webinar are not getting NGS and MDS. I was starting to think it was a little bit more standard and a little bit more commonplace, but I suspect kind of insurance reasons impact that, and also just the fact that for the most part, we don't have specific targeted treatments for a lot of these. Long-winded way to say I support it, though. I think it is important and increasingly so, because the IPSS-M, I think, is quite useful.
So Brady, are you guys using a lot of IPSS? Because it's become standard in our practice, so I was a little surprised to see that it's not in the community.
My practice is a little bit different. I do mostly classical hematology and then MPNs. I can address the question as it pertains to MPNs because it's sort of similar in that our prognostic scoring systems have evolved. They're kind of playing catch up with the other diseases, including MDS, but we now have a similar prognostic scoring system that includes results from NGS. And I agree with everything that's said. That information, it just has to be part of the prognostic assessment for these patients. I mean, we have so much heterogeneity in all of these diseases we're discussing, and it just kind of helps to segregate patients into different risk grouping. And we use it a lot as a component for the transplant discussion for patients with myelofibrosis. So it really helps. If we're looking at just demographics and blood count abnormalities, that's just not going to tell the whole story for the patient with MF. We're not really using it in ET or PV because we have no idea what to do with the result. It'll just increase anxiety levels. So it's a great question.
Perfect. And then I'll quickly answer the last question, which says, do you generally add luspatercept to an ESA or use it as a single agent? I confess that I am still primarily using them as a single agent and haven't started putting them together in combinations. There is a clinical trial, of course, that is ongoing that we are enrolling to, but I think there is increasing data that suggests that's going to be a very effective strategy, which I am not surprised at all. So I will provide key highlights and takeaways from the MDS portion. And the first section is lower risk MDS, and just highlighting that ESAs, luspatercept, imetelstat are all effective treatment options for patients with lower risk MDS and particularly anemia. Luspatercept was associated with improved rates of red cell transfusion independence, increased hemoglobin levels compared to EPO in ESA naive patients, which was confirmed in the COMMAND study follow-up. Higher doses of luspatercept are often required for efficacy. I think that's an important thing that many people don't realize. You can increase from the 1 mg per kg dose to 1.33 and then to a max of 1.75 mg per kg, and often that is required. Imetelstat for patients with lower risk MDS with transfusion-dependent anemia that have not responded to ESAs is associated with red cell transfusion independence in about 40% of patients. And then hypomethylating agents like oral azacitidine may be an option in the setting of failure of the above options for patients with lower risk MDS. And the 200 milligram oral dose for 14 days per cycle did appear to be somewhat better tolerated than the 300 milligram oral dose at the same schedule from the ASTREON trial. High-risk MDS remains a challenge. No randomized trials which have demonstrated superiority of a combination over azacitidine alone, with these summer meetings highlighting both AZA and magrolimab, as well as AZA and sabatolimab, were recently reported as negative. There is still hope. Propensity score matching suggests the benefit of venetoclax to HMA-based therapy in high-risk MDS, and the AZA and venetoclax Verona trial is ongoing and results are anticipated soon. IDH1 mutations are rare overall in MDS, but targeted therapy with ivosidenib is well tolerated and very effective.
Thank you, Dr. DiNardo, Dr. Wang, and Dr. Stein. And thanks to you, the listener, for joining us. As a reminder, to view the full program, Congress to Clinic, Myeloid Malignancies Clinical Advances Journal Club on emerging MPN, MDS, and AML data, and to download a slide set associated with this discussion, please click the link in the show notes. As always, thanks for listening.